They are small, powerful little nuggets. They are actually small signaling proteins that our immune cells use to communicate, and they really help regulate immune activation or inflammation and even the growth and survival of immune cells. When cytokines are used therapeutically in oncology, they help to stimulate immune cells such as T cells or natural killer cells to better recognize and attack cancer cells.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Maribel Pereiras, Clinical Pharmacy Specialist at the John Theurer Cancer Center at Hackensack University Medical Center in New Jersey, about cytokines and cancer treatment. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation that is linked in the episode notes. Thanks so much for joining us again today. Welcome back, Maribel.
Thank you for having me back. I really had a lot of fun last time, and I'm looking forward to this discussion.
Yeah, me too. This is going to be an interesting one. So to start off, let's start with a brief overview of the history of how cytokines have been used in the field of oncology.
Absolutely. And this one has a deep history. Cytokines are actually among some of the earliest forms of immunotherapy used in the treatment of cancer. And it really goes back to the 1980s and the 1990s. We're talking therapies like interferon or interleukin-2 that were used to stimulate the immune system, with the idea that they would recognize and attack cancer cells, particularly in diseases like metastatic melanoma and renal cell carcinoma. What made these therapies unique was that although the overall response rates were relatively modest, when patients did respond, those responses could be very durable and sometimes long-lasting. And that observation was really important for the field of oncology because it was part of the process that demonstrated that the immune system could potentially control cancer in really meaningful ways. With that being said, cytokine therapies have also come with significant toxicity. One quick example is high-dose interleukin-2, which could really cause severe inflammatory reactions like capillary leak syndrome. And that often meant that patients had to go to specialized treatment centers that were capable of providing intensive monitoring. As newer immunotherapies, like our checkpoint inhibitors, were developed, those which were much easier to give, much better tolerated, the cytokines actually began to fall out of favor. With that being said, cytokines are making a comeback. They are reemerging in oncology, and researchers are developing engineered cytokines that are designed to activate the immune system in a more selective manner, with the hopes of minimizing some of those systemic toxicities that we saw with some of our more original old school therapies.
Wonderful. Well, thank you so much for that brief history. Certainly a fascinating class of drugs. Let's talk a little bit now about the mechanism of action. How exactly do cytokines work?
They are small, powerful little nuggets. They are actually small signaling proteins that our immune cells use to communicate from one to the next. And they really help regulate immune activation or inflammation and even the growth and survival of immune cells. When cytokines are used therapeutically in oncology, they help to stimulate immune cells such as T cells or natural killer cells to better recognize and attack cancer cells. A nice example of that is good old interleukin-2, which does work by promoting both the expansion and the activation of T cells. More recently, though, as I mentioned, researchers have focused on some other cytokines, and we're going to talk about interleukin-15, which can help stimulate both natural killer cells and CD8 positive T cells. And unlike some other cytokines, interleukin-15 doesn't significantly expand regular T cells, which can actually then further suppress immune responses. And because of that, interleukin-15 has become quite an attractive target for newer cytokine therapies because they're using it really to enhance anti-tumor immunity while also hopefully easing off some of this toxicity.
Now, we know for some types of immunotherapies or even other targeted agents, We do preliminary biomarker testing or, try to test for certain things that would make somebody eligible to receive a therapy. Are there any biomarker tests or other sort of testing that is required or that a nurse should anticipate before somebody might be prescribed a cytokine therapy?
Unlike many of our targeted therapies in oncology, the cytokines actually do not require specific molecular biomarker testing before they are given to patients. In this case, treatment decisions are usually based on clinical factors, such as what type of cancer are we dealing with, what's the stage, and then very importantly, because again, some of these cytokines can carry some significant risk factors for toxicities, what is the patient's overall performance status? With that being said, we can also talk about their organ function because we know that some of the cytokine therapies can cause significant systemic reactions. And so patients need to be fully evaluated from various organ perspectives like cardiovascular, pulmonary, or even renal function before starting therapy. With a lot of the newer cytokine therapies that are starting to emerge, eligibility is really going to be more dependent on disease characteristics or prior treatment history rather than any specific biomarker or genomic testing. And so this really kind of sets them apart from many of our modern targeted therapies.
Are there any subclasses or categories of cytokines that we can sort of lump or bucket them into or not? And then are there any examples of newer agents in this class that we have seen be approved recently?
I think the best way to break down cytokines, because they represent such a large family of immune signaling proteins, is that you can put them into really two big broad categories. You've got your therapeutic cytokines that work to stimulate that immune system to help, again, fight against the cancer. But then we also have another category of cytokines that some people tend to overlook as such, but they're the cytokines that are used for supportive care to help the body recover from treatment. Historically, therapeutic cytokines were our interferons or interleukin 2. They were some of the earliest immunotherapies used. Their claim to fame was that they demonstrated the idea that activating the immune system could lead to some durable responses. And the two biggest areas where this was seen was melanoma and renal cell carcinoma. We have had in this space, the researchers have been developing more next generation or what is now being referred to as engineered cytokines. The idea with those is we're still activating the immune system, but in a more selective manner while trying to reduce some of the systemic toxicity that was seen with the earlier therapies. One nice new example of an engineered cytokine is nogapendekin alpha ibacestat, which is quite the tongue twister to say. It's a drug that recently came to market. So some people might know it by a more investigational name, N803. But this agent is really interesting because it's engineered interleukin 15 receptor agonist that works on stimulating natural killer cells and CD8 positive T cells. And what makes this so interesting is that it's used in combination with a medication that probably some of us are familiar with, good old BCG, for patients specifically with invasive bladder cancer. The other really interesting thing about this new therapy is that the fact that it is one of our first ones to be engineered in a combination fashion. So the nogapendekin alpha is combined with a receptor component that is called ibacestat. And what happens is it forms a complex to enhance signaling and prolong the activity of the cytokine. And so the idea here is we're getting a stronger immune activation while really limiting widespread inflammatory toxicity. And so that's kind of our first bucket, our therapeutic bucket of cytokines. The next major group of cytokines that we see in oncology are the supportive care ones, which typically tend to be our granulocyte colony stimulating factors that help to restore neutrophils after chemotherapy. We also have erythropoiesis stimulating agents, and those help with managing chemotherapy-induced anemia. And although these are also cytokines biologically, the way they work and function is almost so different compared to their counterparts that we use therapeutically. But this last group, really the primary purpose is supporting bone marrow recovery versus directly targeting the cancer.
Thank you so much for that response. I mean, I think it is always helpful to keep them separated into those two categories. As you clearly described, they sort of live in different worlds in terms of what their use is for, and then how we as nurses need to think about them and be anticipating what effects good and bad might come from the use of these drugs. So thanks for kind of creating those two separate categories that we could sort of think about and talk through the rest of our conversation today. So now let's move on into toxicities. What are some of the common toxicities or adverse events that are typically associated with the cytokines? And just give us some more details if there are ones that are shared across the therapeutic category of cytokines, or if there's lots of unique intricacies for each drug on its own.
While these are all cytokines, depending on whether we're talking about the therapeutic cytokines or those used for supportive care, the groups can behave quite different from a clinical perspective. For the therapeutic cytokines, going back to interferon, interleukin-2, many of the adverse effects are related to a hyperimmune activation and inflammation. And patients will often experience flu-like symptoms, which can be fever, chill, fatigue, even some myalgias. And those symptoms are fairly common and really reflect the immune system being stimulated. Once you get into higher doses or more particular cytokines, then we start to see more serious toxicities enter into the landscape. And the one that has the claim to fame in that department is interleukin-2 when it is used in high doses. That one has a historic background of very interesting toxicities, most notably associated with what we call capillary leak syndrome, which can lead to hypotension. You can have fluid shifts, even pulmonary edema, and from a more severe end, organ dysfunction. And because of those risks, anytime someone was getting high dose interleukin-2 therapy, that really had to be administered somewhere in a more specialized setting with very close monitoring, many times actually in the ICU. Other potential side effects that can happen with some of the other therapeutic cytokines in general can also be tachycardia. We can see increases in liver enzymes and occasionally even neurologic symptoms such as general confusion or somnolence. All of these side effects are really tied to the fact of systemic inflammation and the physiological stress that's going on with immune activation. You contrast that with our cytokines for supportive care, and it's almost like we're talking about drugs from like another world, like you said. So the growth factors, very different toxicity profile. And in this case, it's the granulocyte colony stimulating factors like filgrastim or pegfilgrastim. And those are used with the idea of reducing the risk of neutropenia as patients are getting their chemotherapy. We have the most common side effect from those is really bone pain. And that's occurring because the bone marrow is being stimulated to increase production of white blood cells. Patients might also experience some mild fatigue, some headache, or even injection site reactions, as this category of medications typically is given more often than not in a subcutaneous manner. Some more uncommon side effects with the growth factors have been splenic enlargement, and very rarely, sometimes that does lead to splenic rupture. And so these patients should be educated to report if they're having any persistent left upper abdominal pain or even pain that extends further up. When you go into the erythropoiesis stimulating agents, which help with treating chemotherapy-related anemia, those have and bring in an additional safety consideration. These medications are used to increase hemoglobin levels, but they have also been associated with an increased risk of thromboembolic events, particularly if the hemoglobin rises above what is recommended as a patient's target. So to take a step back and just summarize all of that, when you're looking at our therapeutic cytokines, those tend to produce larger scale systemic inflammatory effects, leading to much more global side effect reactions, while your supportive care cytokines are more commonly associated with either bone marrow stimulation effects or hematologic changes.
Thank you for walking through those, but keeping them bucketed, because it definitely helps me to kind of keep them sort of organized in my brain. Just very interesting. Again, like they're used, it's so differently therapeutically, and some of the negative consequences that can come from that. But then also we see them used in the supportive care realm, which also comes with slight side effects in that realm. And so just going to be important for us as nurses to keep those things clear so that we can then communicate that to our patients as well. Let's talk a little bit about what we can do about all those toxicities that you just covered for us. What are some of the pharmacologic strategies that we could use to maybe prevent or just to help manage the toxicities?
Management strategies are going to depend which cytokine are we talking about. As we've just reviewed, the type of adverse effects that the patient develops are going to be very different between using a therapeutic cytokine versus one for supportive care. And so our approach to pharmacologic management in terms of prevention or treatment are going to vary. For therapies that cause flu-like symptoms like fevers, chills, and myalgias, many times patients will receive pre-medications that can include acetaminophen or nonsteroidal anti-inflammatory medications to help alleviate those side effects. Hydration is actually going to be very important, particularly if patients develop fever or hypotension. When you're dealing with cytokines, those that are given in much higher doses that then lead us to see the more significant inflammatory responses, again, good old classic interleukin 2 therapy, those patients are going to require very close hemodynamic monitoring and supportive interventions. And that can lead to a whole range of medications that we might be providing them. We're still going to treat them with pre-medication to prevent the fevers, the chills, the myalgias. But at the same time, knowing that we might have a patient who has a higher likelihood of developing organ dysfunction, we're going to introduce additional elements to help either treat those or prevent those. In this case, you want to make sure the patient is hydrated, but not overly so, where they could lead into a pulmonary edema situation. And so it's finding a very nice balance of providing support while managing any side effects that may occur. And in this case, when dealing with high dose cytokine therapy, it may be of benefit to have clear distinguishing factors that are being communicated as to when the treatment needs to be delayed or even temporarily interrupted until the patient's symptoms start to improve. Moving over to our growth factors, the management strategy is going to be very different. Many times patients don't need any pre-medication unless it's a patient who's received a granulocyte colony stimulating factor before and they know that they end up with bone pain. Then you can definitely pre-medicate them the second time around. But most of the times, it's reactive management. So should they develop bone pain, you can provide them with analgesics. And it can be simple analgesics, items such as acetaminophen, and even antihistamines like loratadine have been shown to provide some level of benefit to alleviate that bone discomfort. When it comes to our erythropoiesis stimulating agent, the key strategy here is really very careful monitoring of the hemoglobin levels and making sure that you're maintaining those levels within the targeted range. And that can easily be done by dose adjusting how much of the erythropoiesis stimulating agent you're being given, or maybe even giving the patient a drug holiday from receiving the medication. Regardless of what type of cytokine therapy you may be using, across the board, early recognition of the symptoms and proactive supportive care are really important. And this is where many of our oncology nurses play such a critical role in identifying changes that are happening in real time to the patient's condition and helping to coordinate, relay information to the rest of the providing team so that timely interventions can occur for the best care of the patient.
Let's talk now a little bit about the actual administration of these agents. Is there anything unique that nurses should be mindful of and take into account based on the route of administration or any of the processes surrounding the administration of these agents?
Absolutely. There's actual several things that we can discuss that relate to administration consideration. Really depends on which type of cytokine that you're using, but administration considerations can vary quite a bit. And this all depends on the specific type of cytokine that's being used, the dose, and for what rationale. It's very important for nurses to be familiar with the specific protocol for the particular agent that their institution is using. For some of our older therapeutic cytokines, such as high-dose interleukin 2, administration is typically going to occur in some type of specialized monitoring unit because of all those very significant hemodynamic changes that we discussed previously. Typically, these are often done in the inpatient setting, many times even in ICU settings, where patients can be closely monitored for blood pressure changes, fluid shifts, and other signs of toxicities. Many times, high-dose interleukin 2 therapy comes with knowing when are the moments to stop therapy and when does therapy have to be held. So there's a lot of communication that has to be relayed between the nurse and the providing team as high-dose interleukin-2 therapy is usually multiple doses that can be given for a patient. Many cytokines are given either intravenously or subcutaneously, and there's nothing quite unique in those formats. Those are pretty straightforward. I think the key here is knowing how it's being given often leads to how the nurse then needs to monitor vital signs, with intravenous administration usually requiring much more intensive monitoring versus subcutaneous. Once the dose is given, the patient can be monitored for a little bit, but usually symptoms are much more mild. When it comes to our supportive care cytokines, again, going back to our granulocyte colony stimulating factors, administration is much simpler. As I mentioned before, typically it tends to be subcutaneous. The one thing to take into consideration here is that patient timing and coordination with other therapies is going to be very important. The growth factors are typically scheduled relative to when a patient has completed their chemotherapy cycle in order to maximize the neutrophil recovery while avoiding it potentially interacting with the active chemotherapy exposure. So in that case, timing and knowing when and for how long to administer the growth factor is going to be crucial. When it comes to the erythropoiesis growth factors, again, knowing patients' lab values and monitoring those hemoglobin levels to know if giving the next dose is appropriate or if the next dose has to be dose reduced or even held to avoid potential side effects. So in the grand scheme of things, the administration considerations for cytokines really center around understanding the specific drug in question, what are the monitoring requirements, and then looking very closely to timing and coordination against other therapies that the patient may be receiving.
I think those are all great points. To me, it just reminds me of sort of the transition from I would say the scheduling, the logistics, and the challenges that came with trying to bring a patient back 24 hours after their last dose of anti-neoplastic therapies, and they needed to get that pegfilgrastim, and they had to come back again, and they lived far away. And then all of a sudden, the on-body injector came on the scene, and just how wonderful that was for patients so that we could sort of avoid some of those additional trips for them and that scheduling issue for them. And it was for these types of drugs where the timing matters of when they actually receive that dose. And so thank you for pointing that out and just bringing that importance of timing to the discussion. Let's move on talking about patient education. What are some of the key education points that we should be mindful to share with our patients, their families, and their caregivers if they are receiving cytokines?
I think one of the big things here with patient education for cytokine therapy is that it's really going to focus on trying to help the patient and their caregivers understand how it is that the medication works and what type of symptoms they might experience. I feel that one of the most important things to explain is that the cytokines are going to stimulate the immune system and that many of these side effects are going to resemble symptoms of the flu. That's probably the easiest way to characterize it for a patient in terms of something that they might already understand. And so letting them know that they may experience fever, chills, fatigue, or even muscle aches is common. And letting patients know ahead of time about these symptoms usually tends to relieve anxiety if it does occur. They know that it was expected, that this is something that is part of the process. At the same time, another key point is helping patients to understand that even though those symptoms are expected, they need to know when and for what symptom they really should then be prompted to call and contact their care team. So while having mild flu-like symptoms is expected, they really shouldn't be experiencing persistent high fevers or having shortness of breath or severe fatigue. So those are probably side effects where they should really escalate it and be calling back to their clinical team to see what the next best steps are. When we move over to the supportive care cytokines, again, going back to our growth factors, patients and caregivers should understand why the medications are being used. In this case, we're trying to help them explain that these drugs are going to help their body recover from certain side effects of the chemotherapy that they received, whether it's to help recover the white blood cells or the red blood cells after their chemotherapy. So that way the patients understand that these are important supportive care measures that really are going to help them stick to their treatment plan rather than it just being another burden of having to take yet another additional medication. As you pointed out, Jamie, the timing of these medications is really important. And so explaining to patients why they had to come back the next day to clinic to receive these sub-Q injections was really important. I think also for the supportive care cytokines, very helpful to prepare the patient for the possible bone pain that can occur with them when you're using the colony stimulating factors, reassuring them that it is a common effect and discussing strategies on how they can try to manage it to make the experience less concerning. And then, regardless of what type of therapy they may be receiving, always encouraging the patient and the caregiver to communicate early about any new type of symptom is very important. Side effects across all of these medications can be managed much more effectively when they're recognized early. And so having that open line of communication between the patient and the healthcare team really does help to provide the safest care possible.
What are some of the ways that you see pharmacists and oncology nurses collaborating together to manage the adverse events and the toxicities we've talked about today, and also to provide that education to our patients and caregivers and really just serve as a trusted source of information for our patients and their families?
I absolutely love doing education. I love to talk to my nurses about therapies and make sure that everyone understands what's going on, because again, being educated really helps to serve for nurses to empower themselves to be able to give medications safely, as well as serve as an advocate for their patient in case their patient is experiencing side effects. So the collaboration between pharmacy and oncology nurses, I think, is just a very natural one that happens with great success and ends up producing amazing results. The safe use of cytokine therapy is one of those things that highlights the importance of the collaboration. And I feel that pharmacists assist with the complex dosing strategies, as well as how we prepare these medications, and then recommending various means of managing a lot of the toxicities that occur with these medications. On the flip side, our oncology nurses play a critical role in monitoring the patients during administration and helping to identify a lot of these early signs of adverse events and reinforcing patient education. And between the two of us together, it really ends up being a very symbiotic relationship, if you will. We help to educate as to what to look for, what can we do in terms of either preventing or managing the toxicity, what medications are allowed in certain areas to be given. To go back to our amazing high-dose interleukin-2 therapy, you might need to augment support from a hypotensive status. Fluids are not enough sometimes, and so now you need to go to a vasopressor. And so what vasopressor can be used on the unit that your nurse is located? What can be given? When do we need to escalate it up from just our standard oncology nursing unit to maybe the ICU based on where medications can be given? So I feel that that is where the relationship really starts to take a very strong hold between pharmacists and oncology nurses, because it's in the sharing of information of what can be done, what can't be done, the communication that occurs that really helps to bring in that essential safe mechanisms in order to get the patient through, especially when they're having adverse side effects.
Absolutely. I could not agree more. Maribel, what do you think the future looks like for cytokines and their role that they're going to play in the landscape of cancer care?
I think the future is really exciting. We've had these agents for many years. They slightly fell out of favor because of their toxicity profiles, but they are making a comeback. It's really interesting to see how researchers are working on developing these next generation cytokines, the way that they're being engineered to hopefully be more selective while really minimizing toxicity to improve the tolerability. I also think the other fascinating thing about these cytokines is that they're not being used as monotherapy anymore. They're now being looked at in combination with other therapies or even other immunotherapies like our checkpoint inhibitors. They're being looked at in the sense that they may be able to help expand and further activate immune cells that our current therapies rely on. And so it's really interesting that while cytokines were some of the earliest forms of cancer immunotherapy, they're now being reimagined as part of modern combination strategies designed to really further help enhance the immune responses against cancer.
Well, Maribel, thank you again for joining us on another really interesting episode of the podcast talking about cytokines today. As we reach the end of this episode, we like to always run through a series of some quick questions to help summarize some of the great things that we've covered in our discussion. So to start that off, how do you think healthcare professionals should evaluate their hidden or maybe their implicit bias that they might hold about cytokine therapy?
I think some clinicians might still associate cytokines primarily with the older therapies that had significant toxicity and inconsistent response rates. I think it's helpful to recognize that perspective and really acknowledge that the field has evolved significantly. We have newer cytokine therapies that are being engineered to be more targeted, better tolerated. So it's all about keeping an open mind and staying updated on the emerging data. That is very important.
What do you think are some common misconceptions about cytokines?
I think with the therapeutic cytokines, a common misconception is that they're an outdated therapy, that they serve no place in modern oncology. In reality, cytokines played a foundational role in the development of immunotherapy and are now being revisited with this newer engineering approach. And it's going to be very excited to see where they come from. And so I don't think you can count them out just quite yet.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think it's not really emphasized just how important the therapeutic cytokines were historically in demonstrating that the immune system could really produce durable cancer responses. That concept really laid the groundwork for an entire field of immuno-oncology. And even though we do have newer therapies that have taken kind of more center stage, I think the cytokines really helped to bring us here. So I think they really need to be appreciated from where they came from and how they brought us so far.
Is there any additional training or education that you would recommend oncology nurses consume to stay current on this topic?
I think as immunotherapy continues to evolve, and it will, oncology nurses can benefit from staying informed about the new immune-based treatments and how their toxicity profiles are going to differ and actually do differ from traditional chemotherapy. I think the education around recognizing the immune-related adverse events, understanding what these newer biologic agents are going to bring to the table, and knowing especially when to escalate concerns is going to be particularly important as more immune modulating therapies are going to enter into the clinical practice space.
And are there any additional resources that you would recommend that we could share with patients or even with other providers who want to learn more about cytokines?
I use you guys as a resource. So the Oncology Nursing Society, you offer a wealth of information and educational resources that are available for nurses as well as other providers. NCCN has some excellent recommendations as well that focus more on the historical aspects, but where these agents should be used and where they still have a place in therapy. I think one of the big things is that there are some amazing historical reference articles, especially looking at the older agents. It's important to, again, understand where we came from to see where we're going. And then looking towards institutional educational programs. A lot of these management of the high dose toxicities are going to be very institution driven. So based on what your institution can and cannot provide for the patient. So I'm sure if you went looking for it, you'll probably find some type of drug guideline or policy guideline that will help you understand more how and where these medications can and should be delivered in your particular institution.
Well, Maribel, thank you again for joining us on today's podcast. It's been a great episode talking about what I think is a unique and not as well known or understood class of drugs, but as you mentioned, one that has served as the foundation for a lot of immunotherapies and certainly something that we should stay current on. So thank you so much for all the great information that you shared with us today. Do you have any final comments you'd like to share with our listeners?
It was really wonderful speaking with all of you. I really enjoy this. The only thing probably left to add in, again, while cytokines were some of the earliest immunotherapies we've had, seeing them reemerge in these new pathways or new combinations is really fascinating. And I think it's a really good reminder that sometimes science comes full circle as we learn how to use these tools more effectively.
Very well said. Thank you again, Maribel.
Thank you so much, Jamie. Appreciate it.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.